So we'll wait for 2-3 minutes once the participants have joined. Then
Okay,
after 2-3
fine,
minutes,
fine,
we can start.
Okay, fine.
Sure.
Anyone will read my CV or directly I will start the session?
I will.
Okay, okay, fine.
Ma'am, I think we can start the class 7 o'clock.
Okay. Good evening, everyone. Today we have with us Dr. Chandan Pal, who will cover CNS, head, neck, and intervention. Dr. Chandan Pal is Assistant Professor at University College of Medical Science, Delhi. He is MD DNB PDCC in Hepatobiliary Interventional Radiology from ILBS Delhi. He is former senior resident at AIIMS Delhi and former faculty at National Cancer Institute, AIIMS, Jhajjar, Haryana. His areas of special interest are abdominal and vascular interventions, onco imaging and interventions, emergency radiology, abdominal and viscerous radiology. Can you please mute yourself? His awards and achievements are: he has published various publications in national and international journals with keen interest in hepatobiliary interventional radiology. He has presented paper and poster in various national and state conferences and received second prize in poster presentation in Bihar State Chapter of IRIA in 2013. He is executive member of Delhi State Chapter of IRIA, ISVIR and Faculty Association of UCMS Delhi. He is coordinator of Interventional Radiology, classes of Indian College of Radiology and Imaging. He is reviewer of Indian Journal of Radiology and Imaging. Over to you, Dr. Chandan. Thank you so much.
Thank you, ma'am, for your kind introduction. And I'm sharing the screen of my PPT. My screen sharing has stopped. Is my screen visible?
Yes, sir. Screen is visible, sir.
Okay, fine, fine.
You can do full screen mode. Yes, sir.
Yes, 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 yes.
Yes, sir. Visible, sir.
Yes, yes. I'm placing the icons to our opposite. Okay. So, welcome to all of you, and good evening also. I will show 65 cases. So after the 10 cases, I will explain the answer with the, and again I will repeat the same. So please uh, uh, open your the book, notebook, and the pen, and start the spotter. And each spotter will last for the 20 or the 25 seconds only. Okay, and after that, we will move to the next spotter. So I am sharing the first spotter of this case session. Okay, there is difficulty. Okay, so please see the lesion carefully, and it is very important. So I have provided all the section of the images so that you can make the diagnosis very easily. So spotter number one, write down, and after the 10 spotter, I will show the answer. Okay, fine. Now I am moving to the second spotter. And intervention radiology topic include whole body, so not it is limited to the head and neck. So be careful and think about other possibility of the abdomen and the other system also. Spotter number 4. See carefully. It is important and do the practice of this case. This is very good case, and I'm hoping that you will done this case very correctly. So please think about that. Photo number 6. Diagnosis with procedure name. Don't write about this structure, the pictal catheter. Write about the diagnosis and the appropriate management of this case.
Assalamu alaikum. क्या हुआ प्रोग्रेस?
Spotter number 7. Photo number 8. Spotter number 9. Name the procedure. And here is the procedure done. And this is the fluoroscopic images of this procedure. And here is my ring, so don't write about this. this is the newer technique of the radiology. So write down about this name only, and I will elaborate in detail. And the 10th exporter. Then after that, I will explain all the 10 cases. So write down the name of the procedures. So now I am moving to the answer of the all the 10th exporter. So first answer of the first exporter is the Warthin's tumor, and the second is the Budd-Chiari syndrome with the DIPS. DIPS is the direct intrahepatic portosystematic shunt, and third answer is the multiple schwannoma, and the fourth exporter answer is the venolymphatic malformation in the orbit, and the fifth is the multiple hemangioblastoma, and six is the renal artery pseudoaneurysm with coil embolization, and seven is the thyroid hemagenesis, and eight was it was a written mistake by the mistake, and it was the bone biopsy, and nine was the percutaneous gastrostomy, and 10th is a PTBT with the biliary stenting. So I am describing all the from the first, and and this is the first spotter, and this is the case of the Warthin tumor, and we can see here there is a enhancing. This is the venous page of the axial images of the brain, and we can see there is a enhancing nodule in the parotid gland, and we can see also the cystic component apart from the enhancing component. And in the corneal view, we can see there is a mixed type of the lesion. One is the component, the cystic component, and another component is the enhancing. This is the mural enhancing nodule in the superior part of the lesion. And in the sagittal view, we can beautifully see this is the parotid gland, and this is the well demarcated lesion in the superficial lobe of the parotid gland. And the upper part is the enhancing nodule, and the lower part is the cystic nodule. This is the classical picture of the Warthin's tumor. So we should remember about the imaging feature of the Warthin's tumor on the CT scan. So now I am moving to the next spotter, and this is the case of the Budd-Chiari syndrome with the direct intrahepatic portosystematic shunt. And this is the case of we can see the diffuse heterogeneous enhancement in the venous phase. This is the corneal view of the CT scan, and in the venous phase we can see the heterogeneous enhancement of the liver parenchyma, and we can see in the axial section with you can see the lobulated appearance, I mean some cirrhotic type of the appearance of the liver, and also the ascites, and also we can see the collaterals around the periesophageal region, and also in the perigastric region. And we can see there is a narrowing of the intrahepatic portion of the IVC, and the hepatic veins are not visualized and not communicating with the suprahepatic part of the IVC. So this is the case of the classical picture of the Budd-Chiari syndrome. In Budd-Chiari syndrome, we can see the occlusion of the all the hepatic veins, IVC, or both the component. In both the component, when both the components are the stenosis are the obliterated by the chronic thrombosis, then we can do the DIPS. DIPS is the direct communication between the suprahepatic portion, the IVC, and the portal hepatic vein through the stent. So this is a stenting of the communication made between the suprahepatic portion of the IVC and the branch of the portal vein. And we can see this is the color Doppler images showing the good. This is the stent and showing the good flow to the stent, and this is the branch of the portal vein, and here is the IVC. And this is the DIPS, and DIPS is done for the the Budd-Chiari syndrome, when all the veins and the hepatic veins are occluded. That is the important features. And now moving to the third S-portal, it is very easy, and we can see the distribution of these multiple sonoma along the nerve of the which is arising from the neural foramen and the spinal cord, and coming out of just as the brachial plexus cord. This is the course of the brachial plexus cord, and here is also the cord, and we can see this sonoma is reaching to the neural vertebral foramen. So this is the classical, and it is the T2 fat set coronal images, and in the any neurogenic tumor on the T2 fat set appear as a ecozine, appear as a bright signal on the T2 fat set images. That is the classical picture of the neurogenic tumor. So it is important, and we should keep in the mind always. And now I am moving to the third S-portal. That is the very important, and we can see this is the T2 fat set axial images, and this is the globe, means the eyeball, and this is the orbit, and we can see there is a retrobulbar, means the behind the globe there is a cystic lesion showing the fluid level, and one component is showing the T1 bright signal, and another component is showing the slightly darker signal with the sharp margin, the fluid level. And on T1 wetted images we can also see the fluid margin with the T1 bright and the T1 dark signal. And in the sagittal view we can see there is a multiple cystic uh, lesion. So this was the when we are seeing this type of the lesion with the fluid level and the cystic component, then the diagnosis is the venolymphatic malformation. This is the vascular malformation of the types of the and the lymphatic. Venous and the lymphatic both are the mixing. So this is the venolymphatic malformation, that is characteristic features of the venolymphatic malformation, showing the fluid level, and it is not showing the appropriate enhancement on the contrast enhanced imaging. So it is not showing any enhancement in the T1 postgrad images. And this is a very good case, and we can see this is the T1 and T2 images, and this is the SWI images, and again we can see in the T2 sagittal view, we can see there is a syrinx formation, and also there is a rounded lesion, and we can see the lesion is showing the cystic component, means the T1 hypointense and T2 hyperintense signal intensity, and we can see there is a small mural nodules posterior to the cystic lesion, and the nodule is enhancing on the post contrast imaging, brightly enhancing. That is the, and also we can see there is a similar type of the lesion enhancing nodule seen also in the spinal canal. So this was a case of the multiple hemangioblastoma. Sometimes it is associated with the syndromic, sometimes sporadic. So this is the classical picture. So we should always look for the different organs for the hemangioblastoma. We should look also for into the orbit. That is the cleanse point of the diagnosis. And this is the classical picture. It may come also in the long cases also. So, and the another spotter is the this is the MIP images of the CT angiography images, and this is the pictal catheter, and pictal catheter is rounded, it's in the distal end, and we can see in the MIP images this is the renal artery, and we can see there is a there is a there is a outpouching like the enhancement in the subsegmental branch of the renal artery, that is the pseudoaneurysm. And it was a pseudoaneurysm created due to the iatrogenic procedure like the PCN insertion into the kidney. PCN means the percutaneous nephrostomy, and this is the tube for the percutaneous nephrostomy tube. And that's and due to the inadvertent injury to the renal artery leads to the pseudoaneurysm. So when we did the distal substruction angiography through the renal artery, we can see there is an outpouching of the lesion. This is a pseudoaneurysm, and this is the main renal artery, and we can see the subsegmental branch of the renal artery. And this type of this pseudoaneurysm require the coil embolization. So coil embolization was done, and the pseudoaneurysm was obliterated by the coil embolization. So the procedure is and so the diagnosis is the pseudoaneurysm of the right renal artery, and the procedure done is the coil embolization of the renal artery. And this is the axial CT scan images, and this is the T1 weighted MRI images, and we can see this is the trachea, and above the trachea there is a hyperdense lesion, and this is a thyroid gland, and thyroid gland is here is right thyroid gland is lobe of the thyroid gland is not visualized, only the isthmus and the left lobe of the thyroid gland is visualized. So forming this is the hockey stick sign. This is the hockey stick sign seen in the thyroid hemigenesis, and we can see also into the T1 weighted images of the MRI. So this is the case of the thyroid hemigenesis, and name the procedure and the diagnosis of the exporter number 8. And this is the pelvic bone, and this is the iliac bone, and this is the sacrum, and there are the multiple lytic lesion in the sacrum and the iliac bones, and we are doing the biopsy for the bone biopsy to diagnose the nature of the disease, and it was the metastatic disease, and we did the bone biopsy from the posterior approach. And exporter number 9 is the name of the procedure, and this is the tube like the structure, and the inserted into the left hypogastrium, and left hypogastrium is the organ just beneath the left hypogastrium region of the abdomen is the stomach. So placing the tube into the stomach is called the gastrostomy. This is the percutaneous gastrostomy. Nowadays, it is called the percutaneous radiological gastrostomy because it is done by the radiologist. So it is called the percutaneous radiological gastrostomy. When it is done by the gastroenterologist, so it is called the percutaneous endoscopic gastrostomy. And this is the contrast taken through the tube. So the well opacification of the stomach, and this is the diaphragmatic outline of the diaphragmatic outline, and this is the vertebra. So there is no contrast leak, so the gastrostomy is successful. So that is the important, and we should remember that the percutaneous gastrostomy has the indication for if the patient is not taking any food from the mouth because of the aerodigestive malignancy, like the cancer in the mass in the esophagus, or the larynx, whatever be the region, the severe mass in the nasopharynx, oropharynx, obstructing the aerodigestive tract. So we can do the percutaneous gastrostomy. So, and this is the most important procedure and frequently done by the interventional radiologist. And this is the procedure name is the percutaneous transhepatic biliary drainage with the stenting. This is the stent. We can see the wave like the appearance with the radio opaque marker in the proximal and the distal end of the stomach. Sorry, in the distal end of the stent, and we can see this is the left side of the duct, and this is the right side of the duct, and there is an occlusion at the level of the hepatic duct. So we did the left sided PTVD, and we passed the guide wire, and this is the vascular sheath, and through the vascular sheath we inserted the stent and deployed the stent. After the stent deployment, we take the run through the safety catheter, and safety catheter is removed by the 24 days after the stent deployment. So this is the PTBD, the biliary stenting. Now I'm moving to the next part of the so I will show the again the 10 cases, and after that I will explain all the cases. Okay. So please again note and write down your paper on your paper. So 11 number spotter is here. This is the important and this is the challenging case. So 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 carefully write down. If you will write the appropriate answer, then definitely you will have a power or have a brilliant mind, because it is important. I have seen this case till my the career, only one case. So I am putting for your learning purpose, and so please write down. Think about. I will give you the appropriate time. Don't write about this the orbit component. Okay, this is the additional finding. So please look another finding. So actually, this is the dynamic scan of the pituitary gland was done. So look around this area and write your diagnosis. Yes, Walter. And next spotter again. Next 14 number. And this is the important case, and it always comes in the wrong cases also, and that is the important. see the images. See the images, and that is the important. If someone is not saying clearly, then I will tell you after the session with the appropriate, the without the with the zooming out, because I am not zooming proper the images. It is the already fit into the PPT and it is appropriate. I think all are visualizing in the good manner. So the next spotter, that is also important, and this is the classical spotter. And when I was in the resident period, when I was diagnosed this case, I became always happy to see this case. So that's why I am putting this type of the case in front of the you. So please do it, and hope you all do this. This is the classical sign, and also important into the need PG time also. That is important. I am giving the clue. Yeah, another important case for the spotter. It always comes into the spotter in different types of the examination. Now moving to the next spotter, 17 number. So it is also important, and the classical picture of the this region. And again, I am moving to the spotter number 18. This is the classical case, and I think no NEDD for this case. So I am moving to the 19 number spotter, and this is the interventional radiology related matters. So we can think about this catheter, name the A and the B catheter. That is the important for the abdominal intervention, and sometimes in the thoracic intervention we can also use this type of the catheter. So but frequently used in the abdominal intervention. And the spotter number 20, we recognize this instrument A and the B. B is lower down. And yes, I think I'm moving to the answer. So write down all the spotters. And if you want to take the another 1 minute for the tough case of this, then I can move for this spotter. You can think about this spotter again. And because the spotter number 11, spotter number 11 is the important. I have seen only one case in my whole career till. So you can visualize carefully. If you are answering this question, then it will be good for you. So I'm giving the only the 10-20 minutes again more, seconds for this case. That is the important. And I will explain the nature of the enhancement of the pattern. If you are thinking about that, then you will definitely diagnose this disease. That is the classical picture. And when I diagnose this case, I have read about on this entity on the internet, and I can find this was the good case. And so I'm moving to the answer. And so the first case was the cavernous sinus hemangioma, 11 number, and 12 number is the Budd-Chiari syndrome with the hepatic venous angioplasty and the stenting. And the 13 number is the pituitary macroadenoma, and 4 is the type 2 Arnold-Chiari malformation, and 15 is the carotid body tumor, and 16 is the craniopharyngioma, and 17 is cellular and the paracellular meningioma, 18 is the multiple sclerosis, and 19 catheter number A is the Simmons the same catheter, and the B is the Cobra C2 catheter, and the 20A is the semi-automatic biopsy gun, and the B is the automatic biopsy gun. So 11 number spotter, we can see this is the T1 weighted images, and this is the T2 weighted images, and this is the dynamic sequences of the first phase of this scan 1, and this is all the dynamic pages, and this is the post contrast images. So we can see here that there is a T1 iso intense mass, the soft tissue mass like lesion seen, because here is the we can see the cavernous segment of the internal carotid artery, but here is it is encased by this mass, and on the T2 weighted images we can see the here is a T2 bright signal of this lesion, and some the flow void is also seen into the T2 weighted images. And this slide is the superior segment of this segment of the images, and this is dynamic. That's why the coronal images was done, and we can see this is the first phase of the dynamic sequence. We can see on the left side there is a T1 iso intense mass, but in this phase there is no enhancement. But we can see the second phase, there is slight enhancement is seen. And again, moving to the third phase of the dynamic contrast enhancement, we can see the enhancement is increasing and gradually filling all the part. We can see from the first phase, second phase, third phase, and the fourth phase, we can guess there's an enhancement in increasing gradually. And in the final first contrast imagery, we can see almost the lesion is the fulfilled. So this is the classical picture of the cavernous sinus hemangioma. Like the any other hemangioma, that is a progressive filling of the lesion. So here is also the similar imaging feature of the post contrast enhancement. And now moving to the 12 number spotter, and this is again the case of the Budd-Chiari syndrome. We can see here is the IVC, and there is the collaterals, and the hepatic veins are not merging into the IVC, and here is the cannulation is done to the internal jugular vein and the right atrium and the suprahepatic portion of the IVC, and here is the hepatic vein was cannulated, and we did the balloon angioplasty. This is the balloon and filled with the contrast, and after the balloon angioplasty we put the stent inside the hepatic vein, and after the taking the run, there is a free flow of the contrast to the hepatic vein and returning to the suprahepatic portion of the IVC and the right atrium, and the collaterals all are disappearance. Here is the collaterals is also visualized due to the obstruction of the hepatic veins. So this is the case of the Budd-Chiari syndrome with the balloon angioplasty and stenting. So, and the spotter number 13 is the pituitary macroadenoma. We can see the figure of the 8 appearance, that is the T1 iso intense. This is the T1 weighted images, and this is the T1 iso intense, and also the T2 iso intense with the encasement of the cavernous segment of the the carotid artery, internal carotid artery. And on the post-contrast images, it is showing only the peripheral and the subtle enhancement. So it is the case of the pituitary microadenoma. Sorry, macroadenoma. And this is the spotter number 14 is the we can see this the herniation of this cerebral tonsil inside the spinal canal, and we can see there is a long segment of the cerebral tonsil is herniated into the spinal canal, leading to the and also there is the herniation, posterior herniation of the dural sac containing the nerve fibers. So it is the case of the meningomyelocele with the Arnold-Chiari. So it is the type 2 Arnold-Chiari malformation. And this is the important case. And this is the T1 weighted image. This is the T2 weighted image. And this is the T1 cornel. And no contrast image was available because the patient came only for the plain MRI. So on the and also on the plain MRI, how to make the diagnosis of this carotid body tumor. I'm giving the clue. So this is the well-defined rounded mass, and the appears as the T1 majority in the T1 isointense, and T2 slightly hyperintense, and this is the carotid bifurcation of the carotid vessel, or the spaying of the vessels. Both are this is the external carotid artery, this is the internal carotid artery, and we can see how the vascularity is measured, how the vascularity is seen on the basis of the T1 weighted images and the T2 weighted images, because there is a inside the mask we can see the flow wire signal on the T1 weighted also and on the T2 weighted also, that represents the vascularity of the lesion. Yes, definitely sometimes the fibrous capsule or the fibrous septa can also produce the T1 and the T2 hyperintense signal intensity, but extensive type of the T1 and T2 hypointensity is linear and serpiginous type of the appearance, showing the vascularity of this lesion. So this is the case of the carotid body tumor, causing the splaying of the internal and external carotid arteries. So again, the important spotter for the examination, and we can see this is the T2 axial T2 weighted MRI, and this is the flare sequences of the T1 weighted images. Flare images axial, and this is the T2 weighted sagittal images, and this is the T1 weighted cornel images, and this is the sagittal post contrast images. We can see in the T2 weighted images there is a solid cystic lesion. Solid cystic lesion is showing the T2 hypointense, and solid lesion is showing the some types of the heterogeneous appearance. And on the flare, the T2 hyperintensity is seen in the lesion, and the sagittal view the same. The T2 sagittal is showing the same, and the T1 cornel is also again showing the T1 hyperintense of the cystic lesion. It means the cystic lesion is containing the mucinous or the proteinous material, that is the T1 hyperintense and the T2 hyperintense, with some heterogeneous signal below the cystic component. So on the contrast imaging, the cystic component is not showing the enhancement, but the heterogeneous component is showing the enhancement. So it is a type of the solid cystic type of the craniopharyngioma, which is reaching to the cell and the intercellular part and also the supracellular part of the brain, and compressing the third ventricle, leading to the gross hydrocephalus. And this is the case of this is the T1 cornel images, and this is T2 cornel, and this is the T1 postguard axial images. So see, the lesion is T1 isointense the cornel view, and T2 isointense, and on the postcast image it is showing the homogeneous enhancement, and it is also extending to the supracellular location and also in the paracellular location. So it is the case of the homogeneous enhancement, which is the case of paracellular cell meningioma. So this is the straightforward the case. So we can see there is the flame shaped. Sir, my screen is visible. Hello? Hello, sir.
The screen is visible, sir.
Okay,
The
fine.
screen is visible, sir.
And
Sir.
this is the okay. Good, sir. And this is the case of the multiple sclerosis. We can see here there is a flame set T2 hyperintensity at the cholecystomal margin, and these are the T2 the flame set the hyperintensity, and we can also see there is the hyperintensity into the spinal cord. This is the hyperintensity, and so this is the case of the multiple sclerosis involving the brain and the spinal cord both. And this is this is the angiographic catheter used in the interventional radiology, and this is the
In progress. Okay.
this is the Simmons, and this is the Stu catheter, and this is the Cobra catheter. And
Sir, video.
moving to the
Sir,
video
students
is
missed two cases, sir. If we can go back, sir.
okay. Which number?
Sir, previous one case, sir.
19,
After cranial
19,
pharyngioma, sir.
19
After
or
cranial
18?
18th, sir.
Okay, after Kanjuma is the 16th number. Then the 17 missed. Okay. So this is the 17 number spotter of this case. And this is the T1 weighted images showing the iso-intense lesion in the cellular and the supracellular location. And this is the T2 hyperintense, T2 iso-intense lesion in also in the supracellular and cellular location. And in the post-contrast images is showing the homogeneous enhancement. And we can see in the sagittal T1 contrast images, it is also showing the homogeneous. Sometimes the link was not disrupted. I don't know why. Sir, hello sir. हेलो सर. हाँ, पता नहीं क्यों सर कट जाएगी. स्क्रीन शेयर कर रहा हूँ सर. हाँ, ये सर. Just 1 minute. Just hold sir 1 minute. And this is the case of the cellular and the paracellular hemangioma. And I move to the exporter number 18. And exporter number 18 is
Sorry to stop you, sir, but the screen is not visible, sir.
now my screen is visible, sir.
Sir, screen is visible, sir.
Yes. And this is the case of the multiple sclerosis in which we can see this is the T2 sagittal images showing the flame shaped T2 hyperintensity signal intensity at the cholecysseptal margin, and this is the T2 hyperintense signal intensity at the and in form of the flame shaped, and we can also see the same type of the T2 hyperintensity in the spinal cord. So this is the case of the multiple sclerosis. And moving to the spotter number 19, this is the spotter number 19A. This is the Simmons catheter. I'm showing the 17 number spotter again. Okay. 17 number spotter is, I am showing the 17 number spotter is again. So 17 number spotter is the this is the T1 this is the T1 corneal images, and this is the T2 corneal images, and this is the T1 postgad axial images, and this is the sagittal T1 postgraded images, and this is the corneal postgrad images. And we can see there is a T1 isointense mass in the supracellular location, and mass is also the T2 isointense. And on the post contrast images, mass is showing the rounded homogeneous enhancement. And it is also on the sagittal view showing the mass is the homogeneously enhancement, and also was the paracellular location with the broad area of the contact with the paracellular location. And the corneal view, it is showing also the same configuration of the homogeneous enhancement. So it is the case of the stellar and the paracellular meningioma. Okay. And I have already explained about the spotter number 18. So I'm moving to the spotter number 19, the Simmons catheter, and this is the Cobra catheter. The Cobra like the shape, and this is the Simmons catheter. Both are used frequently in the abdominal intervention radiology procedure. And spotter number 20 is the biopsy gun. This is the semi-automatic biopsy gun, and this is the automatic biopsy gun. And the difference between these two is the taking the sample for a single puncture with the advancement technology with the safety procedure. This is the so for the smaller lesion localized to the vessels, and that is the so we can use the semi-automatic gun. And the automatic gun is the 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 automatic for the automatic gun is mainly used for the larger lesion and also for the superficial lesion, and the lesion away from the major vessels we can use the the automatic gun. And in the automatic gun, thrust is moving forward for a length of the 2 centimeter. But in the semi-automatic gun, we can see the tip of the advancement of the your tip, so that it can't move when you fire the gun. So that is the purpose of the safety of the automatic gun. And the semi-automatic gun is less uh, the less safety profile as compared to the semi-automatic gun. And this is this is the automatic gun. So we should remember both these two. We can take the multiple sample through the take the multiple sample with the single puncture with the semi-automatic gun. But for the automatic gun, we should do the we'll have to do the multiple puncture for the multiple sample. That is the advantage and disadvantage of the semi-automatic and the automatic gun. Now I am moving to the another state of the the spotter. So this is the spotter number 21. Spotter number 21 used in the interventional radiology procedure. So we should know this. I am showing all the important cases and the spotters that is important in the day-to-day practice. Spotter number 22. it is also the important, and we should also mention in our abdominal CT scan report also, because I saw majority of the radiologists are not reporting this entity. That's why I am showing this type of the cases. Now the spotter number 23, and spotter number 23, I am giving some hint. This is the cirrhotic liver, and the cirrhotic liver, and these are the procedure. So think about that. Moving to the next spotter. Name diagnosis and name the procedure. And we can move the we can make the diagnosis on the basis of the CT scan, and also through the DSA run. That is the sufficient. And also we can see the procedure, and we can make the diagnosis very easily. But we should we should know this entity very well, and make the diagnosis. That is the important in the clinical practice. Especially for the patient of the chronic renal failure with some dialysis catheter inside the SVC, superior vena cava. Photo number 25, name the artery, and name the artery. Actually, it is done for this some kind of the embolization. So it is important to know about this artery, and this is important. And I'm moving to the photo number 26, and this is the name the procedure. This is the actually this is the procedure done on the breast. So I wanted to know the name of this wire, and I'm giving the some hint. There is a clip in the also the lesion. We are placing the clip in the breast for the malignant breast mass, so that we can localize the breast mass after the chemotherapy. Chemotherapy demands the chemotherapy causes the disappearance of the mass. So if you are not putting the clip, then we could not localize the exact location of the mass. That's why the clip was placed, and again the procedure was done for this purpose. So we should aware of this wire, and this wire is basically the linear hypertense wire, and there is some type of the kink or the hook. So I am giving some hint. So write down. So we should know aware of that. It is most frequently used in the oncology setup. And this is the radio opaque marker used in the mammography room. We can see there is a B, C, D, E, F. These are the markers. So write down the name of the procedure. What is the procedure? So I'm moving to the aspirator number 27. And this is the CT scan images. And the actually lesion is very, very subtle. And this is the contrast enhance the subtraction images. That's why the breast appears very dark in this. And we can see the lesion as slight enhancement, the more enhancement depending upon the enhancing pattern or the vascularity of the lesion. And make the diagnosis. I want to know the diagnosis of the orbital lesion only. And you can write about the bony lesion also. But if you are writing the orbital lesion, then obviously it is the good. So I'm moving to the next spotter, 28 number. And this is the important. So I will move slightly fast because the time issues.
Sorry.
This is 28 number spotter. And this is the 29 number spotter. This is the angiographic images of the, I will give the hint. This is the angiographic images of the chest. We can see the clavicle, we can see the ribs, and we can see the clavicle. So there is some structure passing through this, and the guide wire is also passing through this. And so, and here is also the vessels showing the spider web appearance. I have total number of the 65 spots, so I will move little fast. And the spotter number 30. Write down the radiological diagnosis and the procedure name and catheter name also. This is the important for, and especially patient reported emergency, those who are taking the alcohol. So I'm giving this some hint, and that is the important. So write down the. So now I'm moving to the answer. So first answer is the 21st answer is the gel foam preparation, and 22 is the plug acid retrograde trans orbitation for the gastric varices part O, and the third is the depth test for the
Sir,
hepatocellular carcinoma drug relating with.
Sir, the images are not visible, sir.
Photo number.
Sir, images of the answers are not visible.
Images of the answer not visible.
We are seeing the spotter
now?
number 30, sir.
30.
We are looking at the
Okay.
spotter number
Now
30.
I'm showing the
Yes, sir. Yes, sir. Now it is visible.
30. Okay. Diagnosis, name of the procedure and name.
Now the answer slide is visible, sir.
Yes. I'm showing the answer slide. Okay. So the 21st
No, sir.
answer is the gel
Now
foam
the
preparation.
no, sir. The answer slide is not visible now, sir.
Okay.
Now
No problem. I will explain about all the.
Sir.
Now visible.
Yes, sir. Now it is visible, sir.
Yes. Answers. Okay. So 21st answer is the gel foam preparation, and 22 exporter is the part 2. Part 2 is the short form and is the plug assisted retrograde transvenous obliteration for the gastric varices. It is interventional procedure. And the 23rd is the DEB test. DEB test is mean the drug-eluting bit transarterial chemoembolization for the hepatocellular carcinoma. And 24 is the central venous stenosis and the balloon angioplasty. And 25 is the hypertrophy bronchial artery that causes the hemoptysis in the tuberculosis of the chest. And 26 is the hook wire placement in the breast carcinoma. That's why the distal end is the hook type of the appearance. And 27 number spotted is the orbital metastasis from the breast carcinoma. And 28 number is hyalolithiasis, I mean the multiple stones in the Watson's duct. And 29 number is the superior vena cava syndrome with the angioplasty and the stenting, and due to the some malignant masses. And 30 is the acute necrotizing pancreatitis with pectal catheter drainage, and that catheter was the pectal. So I'm moving to the for the expansion to the 21 number. This is the gel form, the packet, and this is the gel form plate, and we are mixing the gel form. We make like the powder form, and putting the syringe with the three-way cannula on one side of the syringe contain the contrast, and we can move vigorously to make the foam like the appearance. That's why its name is the gel foam appearance. And we can also use the plate for the embolization. This is the temporary type of the embolization used in the interventional radiology procedure. So, and this is the procedure for the part 2. Part 2 is done for the gastric varices. We can see here this is the IVC, and this is the left renal vein. We can see there is a shunt rising from the renal vein and reaching to the, and also communicating with the spleen and forming the collatus around the perigastric region. That collatus is not cured by the endoscopic route because it is outside the gastric lumen. When it is inside the gastric lumen, it is cured by the gastroenterologist. But when it is outside the gastric lumen, then it is only cured by the interventional radiologist. So obviating this, occluding this shunt, we require to put a plug. Plug should be placed just above the crest of the shunt. Here is the crest of the shunt. That's why the plug was placed just above the crest, so that the plug should not migrate into the renal vein and into the IVC. And that is this is the plug, and rest of the material is the exclusion material mixed with the sodium tetrasulfate STS with the some contrast with some the glue we can mix up, and we can deposit into the for application of the gastric varices. That is the important. And this type of if the shunt is very large, then the patient also complain of the hepatic encephalopathy, like the features like the coma, less talking, always sleeping. That is the features of the clinical features of the large shunt. And this is the cirrhotic liver, and we can see this the arterial phase, and we can see there's a well-defined rounded the homogeneously enhancing lesion with the central some types of the necrosis or the non-enhancing areas, and it's in the segment 6 of the liver. And we did the super selective embolization of the hepatocellular carcinoma, and this is the DEB test. That's why it appears the radiolucent and the not the radio opaque type of the lesion, the appearance. And this is the outline of the hepatocellular carcinoma, and this is the some the venous drainage of this lesion. So this is the super selective chemoembolization of the SCC. And and we can see, and this is the left brachiocephalic vein, and it is the superior vena cava, and here there is a narrowing at the stenosis. So this is the case of the left brachiocephalic vein stenosis, and left brachiocephalic vein, superior vena cava, all come under the category of the central venous stenosis. That's why it is the case of central venous stenosis, and we can see the multiple collaterals in the anterior chest wall, and on the DSA and the run to the through the left IGP, we can see the multiple cutters and occlusion of the left brachiocephalic vein, and we took the access through the left brachiocephalic vein, and guidewire is passed through the left brachiocephalic vein through the SBC and into the right atrium into the IBC, and there is a balloon dilation of the left brachiocephalic vein, and we can see the stenosis in the form of the balloon crest, and we are dilating the balloon. Here we can see the crest, and where this appearance of the chest means the full dilation of the stenosis, and we can see after the run there is a disappearance of the all the collaterals. So this is the case of the central venous stenosis with the balloon angioplasty. यस सर, यस सर, वो थोड़ा सा लगता है कि कर्सर की वजह से हो रही है सर। यस यस। हेलो सर, हेलो सर,
Sir, screen
my
is
screen is
visible, sir.
visible.
Yes, sir. Yes, it is visible.
Yeah, okay, okay. So actually, maybe due to the some cursor error. Okay. So this is the case of the hypertrophic bronchial artery. We can see this is the hypertrophic bronchial artery when bronchial artery diameter is greater than the 3 mm. It is the hypertrophy, and when we are seeing the bronchial artery clear without any the giving the more stress on the bronchial artery. If you are seeing the bronchial artery very clearly, then it must be the hypertrophic bronchial artery. So here is we can see the hypertrophic bronchial artery, and we can take the run. And for the hypertrophic bronchial artery on the both side causes the hemoptysis if the bronchial artery is dilated. So the ideal material for the embolization for the bronchial artery is the glue and the sometimes the PBF particle, but not the coil, because coil causes the proximal occlusion of the artery. That is the important. So we can put the glue or PBF particle, polyvinyl alcohol particle for the embolization. So this is the hypertrophic bronchial artery. And 26 number spotter is the placement of the hook wire. Hook wire placement, we can see this is the hook wire, and this is the kinked distal end. It is used to localize. It helps the surgeon to reach out the lesion which disappeared after the chemotherapy. That is the purpose of the placement of the hook wire. So through this hook wire, surgeon reached to the lesion which disappeared due to the chemotherapy. So surgeon surgeon easily remove the area of the mass by visualizing the hook wire and also the clip placement. Sir, my skin is visible now. Hello.
Yes, sir, it is visible, sir.
Yes, yes. And this is the spotter number 27, showing the enhancing soft tissue mass seen in the right orbit. We can see here, and there is multiple lesion in the pelvis. And also, this is the contrast enhanced subsection images. We can see the subtle enhancement in the retroareolar region. And this lesion was the 5 to 6 mm in the size. And and when I did the biopsy, it turned out to be the malignant lesion. And this is the case of the breast carcinoma of the orbital metastasis. So we should always keep in the differential diagnosis of the orbital lesion. In the elderly female of the 67 or the 72 years old, if came with the orbital lesion, then always keep in the mind in the differential diagnosis of the breast metastasis. And this is the case of the hospital number 28. This is showing the hyperdense lesion in the what and the submandibular region, and this correspond to the linear hyperdense region, the Watson's duct. So it is the submandibular duct calculi we can see here. And this is the case of the superior Benakawa syndrome. This was the case of the 25-year-old male with the lung malignancy, came with the features of the facial puffiness, arm swelling, neck swelling, unable to move his head. So we did the left jugular vein access, and we did the run, and we see there is a occlusion on the left brachiocephalic vein with the multiple collaterals. So we did the the guide wire passed through this stenosis, and we did the balloon angioplasty from the both side. And after the balloon angioplasty, we put the stent inside the brachiocephalic vein and the superior vena cava. And this is the X-ray images of the stent. We can see there is a still the due to the hard nature of the mass, still the stent is showing the some narrowing. Yes, but it is opened, and his symptoms resolved spontaneously after the stent placement. That is the case of the superior vena cava syndrome with the SBC stenting. This is the emergency condition, so we should put the stent when patient come with the SBC syndrome. And this is the case of the acute necrotizing pancreatitis, in which there is a fluid accumulation, and we did the percutaneous hepatic venous percutaneous pictal drainage of this connection. So I'm moving to the another set of the spotter. So write down the spotter number 31st. Now I will move little fast. Spotter number 31. And the spotter number the 22. Sorry, 32. Again, same type of the spotter. So I'm giving this some hint. Now moving to the next. This is spotter number 33. Spotter number 33. It is important. And spotter number 34. EG spotter. EG spotter, and important spotter for the trauma patient. So we should know about this entity. It is dangerous entity. So we should not miss this type of the diagnosis. And I'm moving little fast. So spotter number 35. And it is the important for the our country. So important, look the entity. and 35 spot on number, and this is a spot on number 36. Spot on number 36, spot on number 37, spot on number 38, spot on number 8, spot on number 39, spot on number 40. This is the diffusion weighted images only. It is only one image, so it is only 5 seconds is enough, I think. This is the diffusion weighted images and showing the bright signal. So now I am moving to the answer, and 31st answer is the superior sagittal sinus thrombosis, and 32 is again the sialolysis, and 33 is the chorioretinal coloboma or the posterior coloboma. That is the important. And 34 is the diffuse axonal injury, and 35 is the laryngeal tuberculosis, and 36 Cockayne syndrome, and the fast disease 37, and 38 is the diabetic steatopathy, non-ketotic hyperglycemic hemichoria, and 39 is the West Nile encephalitis. If you are writing the encephalitis, that is also the true, and 4 is the Weber syndrome. This is, and I am moving to the 31st spotter for the explanation, and we can see there is a this is the superior sagittal sinus, and we can see there is a filling defect in the superior sagittal sinus. So this is the superior sagittal sinus thrombosis. This is the important clinical entity, and this is again the multiple duct in the submandibular location as a mandibular calculi in the submandibular location, and also in the direction of the Varsus duct. We can see the dilated duct with the stone, and in the coronal view, both the ducts are both the stones are visualized. Actually, one side of the duct and the stone is visualized in the axial view because of the orientation. Actually, I wanted to show the duct. That's why I did some manipulation of the images. And again, we can see in the central view, we can see the stone. So this is the case of the sialolysis. That is the important. And this is the important case. I am explaining in the detail. And this is the normal orbit. And we can see the left orbit is showing the conical projection towards the posterior aspect, the globe. And there is some defect in the posterior coat of the element where the optic nerve attached to the posterior coat of the globe. And the eyeball is appear the shrunken conical, and we can see also there is the fat standing in the retrobulbar fat, and the posterior coat is appear thickened. That is the features of the posterior coloboma. Yes, the anterior coloboma is also seen, but anterior coloboma we could not visualize, and it is mainly concerned to the iris. But posterior coloboma, on the basis of imaging, we should make the diagnosis, and that is the important. We can see the conical projection of the globe with the thinning and the defect, and also associated in this entity is associated with the cellulitis and the panophthalmitis because of the thickening of the globe, and it is usually associated with sometimes it is associated with the cyst formation in where the defect is seen. And we can see in the coronal view the features of the the retrobulbar cellulitis and the thickened globe and the coloboma. That is important. And this is the 34th number spotter, the diffuse axonal injury. We can see the hyperdense the blood component in the chaining of the corpus callosum, and also in the uh, the white matter of the brain. We can see here. So it is a type of the diffuse axonal injury. And again, this is an important case, and again, I have seen this type of the case in the first time in my life. And this is the laryngeal tuberculosis, and we can see this is the level of the false cord. We can see the fluid attenuating area, and also extending to the the strap muscles, sternocleidomastoid muscles. And we can see the fluid attenuating area is very clearly seen and extending to the transclerotic extension also. And in the sagittal we can see the clearly this is the case of the laryngeal tuberculosis. That is the very rare, but yes, we can. And this is the case of the this is the case of the Cockayne syndrome. We can see there is a calcification in the region of the basal ganglia and also in the cerebellum. And on this is this is the PET CT scan, and this is the T1 weighted images. We can see the hyperintensity in the region of the basal ganglia. And on the T2 weighted, we can see the hyperintensity with the some T2 hyperintensity foci within it. That is a feature of the Cockayne syndrome, and it is also associated with the atrophy of the brain. And this is the case of the FAR syndrome. We can see there is again the calcifications in the globus pallidus and the putamen and the chordate nucleus and the subcortical white matter, and also in the cerebellum and all. This is the FAR syndrome or the FAR disease. Depending upon the etiology, we should give the name of this entity. And this is the diabetic stereopathy. We can see here that there is a T1 there is a this is the plain non-contrast CT scan. We can see the hyperdensity along the basal ganglia, putamen, and the chordate nucleus. And we can also see in the T1 evidence here is the hyperintensity. And this is the classical picture of the T1 hyperintensity of the entity, the diabetic steatopathy, also known as the non-ketotic hyperglycemic hemichoria. And hemichoria, and when the CT scan is showing the lesion on the right side, then the hemichoria will appear on the left side on the patient. That is the important. And this is the case of the West Nile encephalitis. We can see the flare hyperintensity of the thalamus, and also the basal ganglia region, and also we can see the medial temporal lobe area. And on the post contrast images, it is showing the some heterogeneous enhancement. So it is case of the West Nile encephalitis. And this is the diffusion weighted images showing hyper intensity on the cerebral peduncle region. So this is case of the Weber syndrome. It is the ischemic lesion. So now I am moving to the next set of the spotter. So this is the spotter number 41. So this is the spotter number 41, and it is also the important spotter number 41. Now I am moving a little fast. So we can see this is the spotter number 42. It is important. Spotter number 43. Spotter number 43. Photo number 44. Yes, photo number 44. Yes, photo number 45. Yes, photo number 46. Look into the spinal cord area. I'm giving some hint. And as photo number 47, quite obvious. And as photo number 48. Photo number 48. It is also important for the spotter. And a spotter number 49. And spotter number 49 and a spotter number 50. After that, I will move to the answer. So write down all the spotters. So now I'm moving to the answer. So first is the vertebral 41. Answer of the 41 spotter is the vertebral artery lobes, and answer to the 42 is the vein of Galen malformation, and 43 is the transspinal meningocele, and 44 is Marcia Fava Bignami disease, and 45 is supracellular giant aneurysm, and 46 is the subacute combined degeneration of the cord, and 47 is spinal cord cavernoma, and 48 sinus pericardi, and 49 Rett syndrome, and 50 is radial band syndrome, radial band sign. So I am explaining from the 41, and we can see this is the arch, and we can see there is the from the arch the common carotid artery is arising, and this is the subclavian artery. From the subclavian artery, the vertebral artery is arising, and the vertebral artery is coursing like the loop. So this is the case of the vertebral loops on the both side. This is the normal variant, and sometimes it is associated with the atherosclerotic, the degenerative changes in the spine, and these are the both are the forming the some loops in the vertebral artery. It is easily seen in the old age people. And this is the important spotter, and this is the vein of the Galen malformation. We can see this is the suprasagittal sinus, and this is the state sinus, and there is an aneurysmal dilation of the vein of the Galen or the promeson capillon, the vein, and it is turning into the suprasagittal state sinus. And so it is a case of the vein of the Galen malformation leading to the obstruction at the level of the cerebral aqueduct, leading to the gross hydrocephalus in the brain. And this is the case of the transspinal meningocele. We can see there is a defect in the floor of the sella, and the dural sac containing the CSF herniated into the nasopharynx, forming the transspinal meningocele. And this is the MRI T2 weighted images, and these are T1 weighted images. So we can see the change of the signal intensity, T1 hypointense and T2 hyperintense, and this is the non-contrast images sagittal view CT. And this is the coronal villosity. We can see the herniation of the dural sac continuous system into the nasal cavity through the sphenoid sinus. It is the transsphenoidal meningocele. And this was the case of the Marchia-Fava Bignami disease. We can see the hyperintensity on the genu of the asplenium of the corpus callosum. It is frequently seen in the alcoholic patient. So it is the important disease entity. And here is the plain contrast, plain non-contrast CT scan of the brain. We can see the well-circumscribed peripherally calcified lesion, and this is the supracellular location. So it is the case of the supracellular aneurysm. Yes, we can see in the detail through the contrast study, but still the differential diagnosis include the giant aneurysm. And this is the axial the titubated MRI, and we can see the hyperintensity in the linear hyperintensity in the dorsal of the spinal the cord, and it is like the inverted V-shaped structure, the inverted rabbit sign. This is important for the subacute combined degeneration of the cord. And it is quite obvious in the intramedullary, the T2 hypointense and the T1 mixed type of the signal is showing the well circumscribed lesion appearance in the popcorn like the appearance. So it is the case of the cavernoma. Cavernoma always appears like this in the brain and the spinal cord. And this is the sinus pericardi. Sinus pericardi is diagnosed by the 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 venogram. We can see there is a deep venous system of the intercalated deep venous system is communicating to the mesentery vein to the extracranial the venous sinuses. So this is the sinus pericardi. We can see the flow wide of the vessels, and here we can see the breast communication through the mesentery vein through the extracranial vessels. That is the sinus pericardi, and this is the supraciliary sinus. This is the state sinus. This is the vein of the Galen malformation, and this is the transverse sinus, and this is the sigmoid sinus, and this is the IGB. So we should remember all the components or all the parts of the venous system of the brain. And this was the case of the Rett syndrome, in which we can see the bilateral frontal atrophy. We can see the increase the circle spaces, and also the thickening of the frontal bones, and the diploic space is widened and the thickened. And the Rett syndrome is always associated with some kind of the bony abnormalities like the scoliosis and the different type of the abnormality of the bones. So it is important to know the Rett syndrome. And this was the case of the radial band syndrome, radial band sign. We can see there is a hyperintense linear structure going through the periventricular region to the subcortical white matter region. On the both side, we can see. So this is the classical sign for the tuberous sclerosis. So now I am moving to the next set of the spotter. So spotter number 51. So spotter number 51 is also used in the oncology setup. That for the basically important for the liver resection. Now moving to the spotter number 52. This is the important case for the spotter. At least each and every people make the diagnosis correctly, I think. Spotter number 53. Spotter number 53. Diagnosis and procedure name. Spotter number 54. Spotter number 55. Spotter number 55. Spotter number 56. Spotter number 57. And spotter number 58. Spotter number 58. Spotter number 58. Spotter number 59. And the number C. Spotter number 60. And and the answer is the first is the total vein embolization, and second is the ophthalmopathy. 52 and 53 is ECM result, and 56 is immunizing macroangiopathy. 57 is the limbic encephalitis, and 58 is the thyroid appearance. So it is pantothenate kinase associated neurodegeneration, and 59 is global hypoxic ischemic injury, and 60 is the ranula. 60 is the ranula. So I am coming to the first F51. This is the right-sided portal vein run. We can see this is the right branch of the portal vein and showing the the the, the segmental venous tributaries. And after the portal vein we can see the liquid material deposition into the right side of the branch of the port vein, subsegmental branches, for the causing the contralateral hypertrophy of the lobe. If you are doing the right-sided portal vein embolization, then after 28 week of the after the 4 weeks, the liver will hypertrophy. And the 52 is the 52 is the orbital ophthalmopathy, in which we can see the enlargement of the extraocular muscles, superior medial rector and the lateral recti muscle, with aspiring of the tendinous attachment. We can see the tendon is aspire. That is the classical picture of the orbital ophthalmopathy. And and this is the case of the giant aneurysm of the ACOM, anterior communicating artery. And we can see there is a hyperintensity seen in the along the fox and also in the sulcal spaces of the right frontal lobe. And in the MIP images, we can see there is there is a aneurysm, and this is the run through the to the internal carotid artery and the SCS. And this is the showing the coil embolization of the pseudoaneurysm. This is the this is the detachable coil. We can detach the coil when we reach the at the side of with the coil embolization. And this is the case of the pneumosinus dilatans, in which we can see the dilated the sinuses. And this can lead to the also the pneumocephalus when traumatic. And we can see in the 55 images, 55 better, we can see there is a calcification along the posterior longitudinal ligament. And it is sometimes times it is appear as a continuous or the discontinuing, and mostly seen in the thorax region. And on the T2 weighted images, we can see the T2 hypointense calcification along the posterior longitudinal ligament. So this is the case of the ossification of the posterior longitudinal ligament. And this is the case of the mineralizing microangiopathy. We can see the calcification at the border of the subcortical white matter, and also in the lesion of the basal ganglia. And also we can see the calcification also seen in this even in the cerebellum, and also in the subcortical white matter. So again, this is the case of the limbic encephalitis. We can see here here the hyperintensity along the hippocampus and the medial temporal lobe on the parietal side, and it's symmetrical, and also involving the splenium of the corpus callosum. So this is the limbic encephalitis. And this is the classical picture of the tegroid appearance of the PK kinase deficiency. And we can see this is the mineral deposition on the T2 weighted the imaging. We can see the tegroid appearance of the putamen, and T2 hypointense with T1 T2 hyperintense T2 hypointense with central T2 hyperintense signal intensity on the both and the symmetrical side of the globus pallidus. And this is the case of the global hypoxic ischemic injury. We can see the multi level of the hypoxic hypoechoic hypodense this in the density along the brain, even on the basal ganglia and the external capsule and the subcortical and the cortical white and the region. So this is the global hypoxic injury, and it is the very important spotter and the easiest spotter. The uh, we can see the fluid like the structure seen in the midline of the floor of the mouth, and also extending the left side of the region. It is the type of the fluid adherence structure. If you are seeing in the floor of the mouth, then it is the ranula. Ranula is the soft structure, so it can seen in the floor of the mouth. And I think one question is asking about the Marcia Fava Bignami disease versus the global cytotoxic injury of the corpus callosum. Actually, the both are the same entity, but there is certain difference, because the global injury of the corpus callosum appear as the focal or the asymmetric type, but the Marcia Fava Bignami disease also comes under the metabolic cytotoxic category, and it is alcohol related, and it is usually seen to involve the corpus callosum in the symmetrical manner. But in the cytotoxic injury of the corpus callosum appears as the asymmetrical pattern. That is the important differentiating point. And now I'm moving to the exporter number 61. 61, exporter number 61. So this is an important exporter. This is the exporter number 2. Sorry, 62. And exporter number 3, 63. This is a classical case. And 64 number. All are very important. And 65 is also important. And 65, important exporter. And, and this is the last exporter of the session. So now I'm moving to the answers of these 5 spotters. So first is the hair on end sign, and 62 is the nasal meningocele, and 63 is acoustic neuroma, and 64 is meningioma, and 65 is epidermoid cyst. So I'm explaining the first spotter. 61, we can see there's a dural thickening with the some hair and the hair and end type of the appearance. It is seen in the hemolytic, like the sickle cell anemia and the thalassemia like the patient. So it is important. And the 65 is the 62 spotter is we can see this is the ethmoid sinus, and we can see the T2 hyperintense signal intensity seen in the through the smart through the smarts and also in the nasal cavity. So this is the case of the nasal meningocele, and through the defect of the maybe the cribriform plate defect. And this is the spotter number, the 63. We can see this is T1 weighted images, and we can see there is the on post contrast images we can see the heterogeneous type of the enhancement, which is some non-enhancing dot like the structure. So and also extending into the internal auditory meters. So this is and forming the ice cone sign. So this is the case of the acoustic neuroma. And again the lesion of the CP angle, we can see the homogeneously enhancing the lesion all seen, and also extending into the internal auditory canal, but there is a thickening and the enhancement of the dura. So dural tells sign. So and the lesion is enhancing homogeneously. So it is a case of the meningioma of the CP angle. And the last spotter. So this is the T1 weighted, T2 weighted, and this is the flare.
Yeah, just a minute.
Yes,
That's not good, right?
65 spotter. So this is the diffusion rated images, and this is the ADC images, and we can see the lesion appears predominantly the T1 hypointense and T2 hyperintense with some heterogeneous type of the signal intensity, and on the flared it is showing the heterogeneous type of the appearance, and on the diffusion the lesion is showing the some area of the diffusion hyperintensity. On the NDC it is showing the the hypointense signal intensity. It is showing the restriction. So it is the case of the cerebropontine angle epidermoid seed that is the important for the spotter. So we should remember about all this entity very well. So this was my last spotter, and thank you for your kind attention.
Thank you, sir, for this wonderful session and also showing us such a great variety of cases. And I hope students also learned a lot today. And I request participants to be ready for the next class tomorrow. And also one small message, you can also post your doubtful cases in the Radiology Without Tears group on the WhatsApp or the Telegram for a healthy discussion. It will enrich everyone. So that's it for today. Good night, everyone.